ladies and gentlemen, we move on to, do we have Dr. Binoy John in the audience? Okay, we don't have him. We move on to the last presentation of this session that features on the emerging giant viability imaging by PET. Our invited speaker is Professor G.N.Mahapatra. He is the founder president of the Nuclear Cardiological Society of India, and he has the credit of introducing the nuclear myocardial perfusion imaging in India, the first of its kind in 1988. And he also is currently heading the Department of Nuclear Medicine and PET at the Seven Hills Hospital in Mumbai. For the next 10 minutes, Professor Mahapatra, please.
Thank you, Chairperson. I'll be speaking on the emerging giant viability imaging by PET. This is my Seven Hills Hospital in Mumbai where I work. So why assessment of myocardial viability is required? To evaluate the injured myocardium following ischemia or infarction, viable myocardium is most likely to benefit from revascularization, whereas a scar tissue is unlikely to show functional recovery. To subject these patients for revascularization in the form of angioplasty, CABG, or in case of scar myocardium, you can subject them to cardiac transplant or very recently stem cell therapy. So what is the concept of detection of viability? It is unquestionable that viability is one of the most important aspects of the diagnostic and prognostic workup of CAD patients. Many endpoints have been proposed for understanding and diagnosing myocardial viability, including preserved cellular metabolism, membrane integrity, perfusion status, presence or absence of apoptosis, preserved contractile reserve, and metabolic reserve. So what are the nuclear techniques? There are so many nuclear techniques. Thallium-201, when we started about 3 decades or 4 decades back, we have a huge database. Then technetium labile agent came, then technetium taurursine, then combined fatty acid with perfusion tester, then lastly, on which I am going to talk to within about 8 minutes, fluorine-18 FDG metabolic imaging. So what are the different PET imaging agents? The most commonly used is fluorine-18 fluorodeoxyglucose FDG, which is available from a in-house cyclotron or a regional cyclotron. But there is an agent, rubidium-82, which is a generator produced. The generator can be supplied. You can take out rubidium-82 and do a PET myocardial perfusion imaging agent. Then on the card, which have just come, a new F18 fluoropyridines, which will be available very shortly with coronary flow reserve as compared to which I have heard fractional flow reserve and other calculations and other things. Then we have a C11 hydroxyephedrine. I'll be talking about this. These are recent advances. And then the fatty acids and all these things. So what do we see in the assessment of myocardial viability by various nuclear techniques? We see viable myocardium, ischemic or geoparadise, stunned or hibernating myocardium, they are all ischemic myocardium, non-viable myocardium, scarred myocardium, where nothing will help. So this is slide which I am showing you. This is a slide where angioplasty has been done, and you are seeing a fixed perfusion defect here in the anteroseptal wall, in the stress and the rest image. So what benefit the patient got? Nothing. The angioplasty has been done and the patient is having shortness of breath and symptomatic, and what benefit we have given to the patient? But unfortunately this patient was not subjected for a stress myocardial perfusion scan. So there are 2 subsets that are called stunned myocardium. After an ischemic insult, coronary blood flow restores, but myocardial function continues to be decreased. Biochemical metabolism persists. The reduction in blood flow initially causes contractile dysfunction that persists after the blood flow is restored, referred to as hit, run and stun. The recovery of contractile function is related to the duration of severity and size of ischemic insult and may take days to weeks to months for its function to improve. The changes in the myocardium in the case of stunning are largely metabolic, showing either normal or mildly degenerated cells. So repeated stunning causes changes in myocardial structure which can be severe and produce hibernation. So now comes to the hibernating myocardium. What is hibernating myocardium? It's an abnormal resting ventricular function due to severe chronic persistent painless myocardial ischemia at rest. Hibernating myocytes exhibit no histologic evidence of scar or acute ischemic damage and most have fairly severe cellular defects. So it is reversible with revascularization procedures detected as hypokinetic or akinetic region. So what are the imaging techniques for the viability hibernation assessment? Viability directed revascularization would improve cardiovascular outcomes, reduced heart failure symptoms, reduced admission to the hospital, and improve quality of life. So you must be thinking how much is the minimum amount of viable myocardium which you should detect by PET or by myocardial perfusion scan, where the benefit or by the revascularization. So minimum is 15 to 20% is the amount of viable myocardium where you can do the revascularization and the ejection fraction and everything would improve. So the minimum amount should be detected in our technique by 15 to 20%. The outcome with this level of viability when the patient is managed even medically or undergoing revascularization procedures. So now comes the positron emission tomography. So defines a metabolic cell integrity and is the most sensitivity modality for detecting hibernating myocardium. PET system manufacturers in combination with CT scanner gives 16, 40, 64 and 128 slice, provides robust attenuation correction which is useful in imaging obese and female patients. With three-dimensional PET system has increased count statistics allowing for reduction in radiation dose per scan. So time of flight, that is TAF capability, which enables more accurate localization of the lesion and by injecting less amount of radio tracer, hence improving spatial resolution of PET imaging. Here you see we have this type of PET CT scanner. It's a high definition 40 slices per second from somatum. So, and this is our SPECT CT, because in PET metabolism we first do the perfusion resting scan followed by the PET. So this is a SPECT CT, and by CT we do the attenuation correction to take out the false positivity in the scans. So radionuclide PET imaging are of two types, that of either perfusion or metabolism. Metabolism PET tracer are rubidium 82, fluorinated FDG and fluorinated pluralidar. The main PET metabolic tracers used commonly is fluorinated FDG in day-to-day practice. FDG is a glucose analog and is therefore a surrogate marker for glucose use. Glucose is phosphorylated to FDG phosphate by the enzyme hexokinase and taken up by the myocardium, resulting in intracellular accumulation of FDG phosphate. The PET viability imaging protocol, what we use, most commonly used technique is to perform rest perfusion imaging and to compare this with FDG effect in imaging. Glucose and FDG uptake is favored by the myocardium over free fatty acid by either using an oral glucose overload we give or to the admission of insulin together with glucose euglycemic IV insulin clamp before FDG injection. Initially, a low-dose attenuation correction scan is first performed, followed by a rest perfusion imaging, where an either PET flow radionuclide or SPECT flow radionuclide injected. So metabolic imaging then undertaken with the admission of 5 to 10 MCI of FDG, and tomographic images are usually obtained 30 to 15 minutes after the injection. So here there are images where you can see thallium 201, there is a defect in the anterior wall and apical wall, and the anterior wall is reversible with FDG part and showing viable or hibernating myocardium. This is a patient where you can see the fixed defect either in the apical area, in the thallium and the FDG PET showing scar myocardium. Here you can see that beautiful description of the anterior and apical defect and the first slices, row slices, and the second row slices showing FDG metabolism, showing FDG metabolism and showing viability. This is another patient where you can see that there is anteroseptal perfusion resting defect where the PET image showing that FDG metabolism, that a mismatch, the perfusion absent and metabolism present, suggesting of hibernating or viable myocardium. Here you can see the beautiful case of dilated ischemic cardiomyopathy, where the ejection fraction is 18 to 20%, and the patient has been referred to us to find out the FDG viability. And you can see the clear-cut viability in the inferior segment of the myocardium in the second row of the images. And you can find the ejection fraction is about 19%. This is another patient where you can see the anterior and apical defect showing viability in the FDG image. So this is the ejection fraction of 22%. So what is the new concept in the viability imaging to direct device type? So what to see that cardiac sympathetic neuronal dysfunction has been shown to be abnormal in viable myocardium, which can cause arrhythmic events leading to sudden cardiac death and heart failure. Suppose you have given a patient, okay, fine, this patient has got a viability studies, and suddenly you will hear the patient has collapsed. So here there is a neuronal dysfunction, autonomic dysfunction, which can be imaged along with the PET viability. So the new PET agents such as C11 hydroxyepidurine can pinpoint effectively as compared to iodine 123 MIBG imaging. I'll take one or two slides. In the area of neuronal dysfunction in spite of having viable myocardium. So neurohormonal and viability hibernation, which you can image with our nuclear medicine technique, may play a complementary role in defining patients who needs an urgent direct device therapy, that is CRT and etc. Here you can see the first row of image is the perfusion scan where you can see the inferior and the posterolateral defect. But this is the first row is the iodine 123 imaging and the second row is the perfusion imaging. You see the perfusion image almost normal. But here there is a huge difference in the inferior and posterolateral defect. This is because the iodine 123 MIBG imaging. So here the hormonal mismatch with the perfusion scan. So who do I send for FDG viability imaging? Known or strongly suspected ISD with NHY at 2 or moderate to severe LV dysfunction, ejection fraction less than 30%, moderate to large persistent perfusion defects, no significant ischemia, the presence of significant comorbidity or poor distal target, or equivocal viability results on another test. So in concluding, the best treatment strategy for patients with prior history of MI or ischemic cardiomyopathy, the benefits and risk of revascularization must be carefully evaluated. Viability and subsequent hibernation is only one of the predictors of outcome benefit from revascularization. Other predictors include extent of ischemia, scar, and left ventricular global ejection fraction. So, FDG PET is not the emerging giant, but an established giant in determining the amount and extent of viability since more than 1.5 decades. Patients with known or strongly suspected CAD, moderate to severe LV dysfunction, moderate to large persistent perfusion defects with no significant ischemia and significant comorbidity would definitely benefit from the gold standard FDG PET viability imaging. This is the last slide where I am showing my society, Nuclear Society of India. It is inviting everybody to have the 10th biennial NCSI conference where our chairperson Dr. Amitabh Arya is holding and Dr. Gambi at SGPCI. This is our 10th biennial NCSI conference. I would invite, please come and attend, interact. This is my baby for which I have grown from 1995 till today. So we have completed 10 biennial conference where there is a common platform. We can interact with the cardiologist, echocardiographer, invasive cardiologist, cardiac surgeons, physician on a common platform to come out a consensus. Thank you very much for your patience here.
Well, as Dr. Mahapatra said, many years back, when we used to get patients with myocardial infarction with severe LV dysfunction, we condemned them. We said nothing can be done, it is irreversible. And there was very much contraindications. But subsequently it was realized that it is not so. 3 causes of a significant LV dysfunction in these ischemic heart disease, either a myocardial necrosis or a stunning or a hibernation. So what became a contraindication became a for a revascularization. And as he mentioned, stunning is a temporary process. It stuns but does not kill. And hibernation is because of a critically stenosed coronary artery with a chronic ischemic dysfunction, and they are the persons who are very well recover following a reperfusion as compared to persons. And it was well shown over 20 years back that revascularization of a viable myocardium has an excellent prognosis And as he mentioned, a revascularization of a non-viable myocardium has a poor prognosis. So now the concept is that whenever you get an LV dysfunction, before any revascular procedure, please for viability. Now without any sort of a unbiased, this low dose dobutamine
Yeah.
has been found to be equally more or less sensitive and specific as compared to a PET scanning. And we can see for a stunning and a biphasic response going up to see for any hibernation. So if we can get a slightly similar information with only 2,500 rupees, why should we go for a PET scan in every case, and why not go for a low dose dobutamine echo or a myocardial contrast echo?
In low dose IV dobutamine, it's a very good technique for the assessment of myocardial viability, except one third of the akinetic segments which you get in IV dobutamine. Then you go on increasing the dobutamine. But still, that one third of the akinetic segments showing no perfusion, no viability on IV dobutamine, it shows in our FDG PET scanning viability. So the patient would get benefit. This is the only thing. But it's a very good technique and very cheap as compared to PET, which has PET myocardial viability about 10,000 rupees, and a stress thallium myocardial perfusion scan which charge about 7,000 rupees, as against MRI 18,000 rupees. Okay.
So now we go for a low dose, because low dose tells you the stunning, whether there is or not, and a high dose will tell you whether there is an ischemia at high dose or not. So that is, there are various techniques, and all of them are complementary, but considering which is easily available, you can do on a day-to-day basis, immediate diagnosis, and of course the economic point of view. So there are all these techniques, but viability must be demonstrated in every patient of a myocardial infarction with LV dysfunction.
Other questions? Thanks for the nice lecture, sir. Now, after this lecture, do we go with the idea, as said by chairman, that any patient with an LV of around about 35 to 40 should have a viability test for all cases?
Yes. Yes, definitely. The first slide which I showed, I don't want to name the cardiologist who did the revascularization procedure. First slide before I went to that. There is a fixed perfusion defect. There is a scar tissue. And the cardiologist did not do the viability study. He went on revascularization things, and the patient went home and then came asymptomatic about shortness of breath and asymptomatic. So what the hell, why the cardiologist did the angioplasty and revascularization procedure? So what Dr. Parasar has told, any patients having LV dysfunction or a past history of myocardial infarction, they must go either the techniques. I am not taking that they should go to a PET. They can do MR, they can do IV dobutamine, they can do perfusion scan. Yes, what you asking is it's a must for any patient after going.
Answering your question, because normally these patients undergo an echocardiogram, and if you are already seeing a dense fibrosis and scar, then that means it is a non-viable tissue. If a diastolic now less than 5 millimeters, it is possibly a non-viable tissue. So if you are contemplating a revascularization procedure or something, then you have to show viability, but not that if there is already a cardium, fibrosis, scar, aneurysm, then there is no point in doing
Is
it.
it only for the ischemic myocardium or for the non-ischemic myocardium also?
I am talking what he told about if suppose all these modalities they give, you have think that is a scar tissue. So what benefit you are going to get benefit to the patient? The scar tissue, if you will revascularize or you will ask the patient to do lifestyle changes or yoga, anything, the scar tissue cannot be converted to a live tissue. So why? Either the choice with the patient, what you're talking about, either the cardiac transplant or the recently stem cell therapy or medical treatment.
See, the medical ethics have gone to this standard. Now we are seeing patients who have undergone a CABG or an angioplasty on a dead myocardium, and there has been no improvement in their death, and they have further deteriorated. But as rightly pointed out, if you are don't condemn a patient because he got an LV dysfunction. Yeah. Any revascular position will help him. And Dr. Satyavan Sharma wants to say something.
In syndrome X, which is the investigation is the best and which treatment is best for this? For madam, which is in syndrome X, which is the best investigation and best treatment for
See, the way I look at it is, I think cardiac MR and a perfusion scan on cardiac MR is possibly your best investigation of choice for a syndrome X. And you're looking for microvascular obstructions and a sort of a transient ischemia that you get in the subendocardium of these women. So MR perfusion is an excellent modality.
So the last comment from Professor Satyavan Sharma.
Uh, Actually, I think we should not take the debate, too much one-sided. The assessment about the myocardial viability is important, but a clinician is most important, and a clinician decides whether a revascularization is necessary by multiple things. And the most important thing is begins with the clinical assessment. If a patient is having a good amount of angina,
Mike.
if a patient is having angina, most of the times, this is the patient who is having a viable myocardium. And there are multiple things which you go, whether you adopt a dobutamine, echo, MRI, or a nuclear is another. And I want to bring a point that an absence of viability always doesn't mean that the patient is not going to be benefited. There is a big trial called as a STITCH trial, in which patients following revascularization have been benefited even in those patients where there was no viability. So I think we should let us not stretch the viability too much. Viability is one of the parameters when we take a decision. It's an important
trial is a very old trial. I know about the
It's not a very old trial. It's just a 5-year-old trial. And in fact, we have our own experience of doing angioplasty, of doing bypass surgery, patients not having nuclear PET scans negative, and patients have lived quite longer. So I think let's not, it's an important parameter, but it's not the only parameter. It is one.
That do you get some of your patients tested for viability or never?
No, we always test.
No,
in fact,
he does.
We believe quite a lot on MRI. We believe quite a lot on PET. And what you said on low dose dobutamine is a standard.
Yeah.
We do every patient. In fact, many patients we do all the three. And despite sometimes we take a clinical decision, if the patient is having good quality vessels, patient is a young patient, there are a lot of favorable parameters. Even if there is a lack of viabilities, we do revascularize the patient. And this is not our practice. This is even part of the recommendations. So I think viability is a very important thing, but no viability means nothing is not the answer.
Professor Mohanan has come from a long distance, all the way traveled a globe. So we'll give him just 1 second.
I'm going to just say one thing on
Same
the
thing,
STITCH.
okay.
I'd like to say something on the STITCH trial now that you brought it up. The STITCH trial, I think what goes against the STITCH trial is that the trial was based on SPECT and on echo. It did not have MR or PET in it. So they are actually redoing and relooking at some of the data on it. And I think we really have to, despite the fact that it was such a long and elongated trial and we were hoping to get so much out of it, I think unfortunately we've sort of backfired. And as far as dobutamine stress echo is concerned, I think it's an excellent modality because if you talk about sensitivity and negative predictive value, then you have PET and MR very close to each other, with MR being a little superior. Like I showed you in my slides, it's 95 to 92% sensitivity. But if you're talking about a positive predictive value with specificity, then low dose dobutamine echo with MR are the two modalities that you're talking about. So the dobutamine stress echo is an excellent modality if you're talking about specificity, but if you're talking sensitivity and negative predictive value, then you're at PET and MR.
Okay, thank you for the comments. We had a very excellent session. Lot of the doubts have been cleared, and now I have been sending many patients unnecessarily for CT coronary angio. I'll stop it from tomorrow. Thank you very much. You have removed our doubts. It was a very illuminating session. Then we gave a good hand to all the speakers. Well done.
Thank you very much, Colonel Parashar and Professor Arya. Ladies and gentlemen, we are very happy to have the President CSI and the Chairman Organizing Committee here with us.